let's now start with a very interesting topic regarding transplant surgery. And before we start discussing about transplant surgery, I want you to watch this clip and understand how a transplant is not to be done. What is the wrong way to do a transplant? And then we'll discuss the right method as well. So in this clip, you can see all the wrong methods to do the transplant. And the thing which is lying on the ground is the heart, right? And now you can see this person is running with the heart. And how is the heart going to be transported here? Not in the UW solution, which I'll tell you. It is just going to fly and going to shatter the glass and directly going to enter the patient's thorax. The surgeon is doing all the unsterile techniques. He's talking on the phone, and now suddenly he'll just cut the phone and he'll happily start suturing it up. And I want you to see the suturing technique which he's using, which is an unnamed suturing technique, unnamed thread which he's using for suturing. And that's not how you cut the suture. That's not how I've taught you. So this is the wrong way of doing a transplant, but good for a few laughs. Now let me just show you a clip where a junior of mine, who's now a transplant surgeon, is just showing how the heart is retrieved and how we transport it. So you can see here the heart is being retrieved. And now once the heart is retrieved, it's a serious affair. Everyone knows their job. They are going to remove all the threads which were being used to harvest the heart, and once that is done, you can see it's being kept on ice, and the cold ischemia time starts. Somebody notes down the cold ischemia time as soon as the heart is retrieved. So as you can see, the organ does not fly like in that movie clip. It is transported in a methodical manner, and that is what I will be discussing in this module. I'll talk about the donors, I'll talk about how the organs are transported, and then we'll talk about individual organ transplantation and what are the points which are important for your exam. So the first thing which you should remember are the types of grafts. This I've covered in the plastic surgery module as well, but this is a constant question which is asked in the exam, so you just want to reiterate this. Autograft is when the graft is taken from the same person, like in skin grafting. Isograft is when you take a graft from an identical twin. Allograft is same species. So if you're taking the kidney, if you're taking the liver, or if you're taking the heart from some other person and transplanting it to another person, that will be an allograft. Xenograft is different species, and you all would have recently read about a pig heart which was transplanted in a human. And heart valves, pig heart valves are commonly used in humans. Porcine heart valves are commonly used. So these are the 4 types of grafts which can be there. Now the source of organs can either be from live donors or it can be from dead donors, right? So you can either have live donors, like if a person is donating one of his kidney, right, or a part of his liver. So those are all live donor transplants, whereas you can have a dead donor transplant as well. And for dead donors, there is a Maastricht classification, which is very important. It is given in Bailey and Sebastian, and lots of questions have been asked. So this is regarding dead donors. This is the Maastricht classification. This you should know. So Maastricht type 1 is when the patient is dead on arrival. That means you are the emergency doctor and you get a patient who's been brought dead to the hospital. Now, we don't know for how long has this patient been dead, right? So we don't know what is the viability of the organs in these patients. So that is why this is an uncontrolled situation, and the only thing which you can take from this patient are heart valves and the cornea. Only heart valves and cornea can be taken. 2 is a patient who has an unsuccessful resuscitation in the emergency room. So you know that the patient has died right in front of you, but again, you don't get time to take consents, you don't get time to prepare yourself. So this is also an uncontrolled situation, and at the most you can harvest the kidney along with the heart valves and cornea in this patient. Type 3 and type 4, according to Maastricht, are very important. These have been asked in the exam. Type 3 is anticipated cardiac arrest. That means there is a patient who's admitted in the hospital where you know ultimately his heart is going to stop. Maybe because of organ failure, maybe because of trauma. You know that this patient is going to have a cardiac arrest. So in that patient, this is a controlled class because you get time to prepare yourself, you get time to take the consents, and you can harvest all the organs. Cardiac arrest in a brain dead donor, where you know the patient is brain dead and now the patient is going to have a cardiac arrest sooner or later. Again, it's a controlled class where you can prepare yourself and you can take all organs. And finally, you have an unexpected cardiac arrest in a hospital inpatient, that is class 5. You don't get as much time as you get in 3 and 4. That is why this is an uncontrolled class, but you can harvest all the organs. So this is the Maastricht classification. Now, once you've harvested the organ, it does not fly like in that movie clip. It is transported in a methodical manner in the UW solution. Now, the UW solution is the University of Wisconsin solution. It is the University of Wisconsin solution, and the organ is transported at 4 degrees centigrade in the University of Wisconsin solution. The key constituents of the UW solution are adenosine. This adenosine will provide energy. You have lactobionase. Lactobionase is a stabilizer. And you have glutathione and allopurinol. You have glutathione and you have allopurinol. They will act as free radical scavengers. They are going to be free radical scavengers. Okay. So these are the 4 key constituents of the UW solution in which organs are transported. Now, you can't keep an organ in this solution forever. So all organs have a cold ischemia time. The cold ischemia time is the maximum time you can keep the organ in this solution. So you need to remember the cold ischemia times of all the organs. They have also been asked in the exam. This is the table directly from Bailey, and you have the maximal and the optimal cold storage times for various organs. So kidney has the maximum cold ischemia time. The optimum is less than 18 hours, but maximum is 36 hours. Liver is less than 12 hours, maximum is 18. Pancreas is again less than 10, maximum is 18. Small intestine, very important, less than 4 hours, maximum is 6 hours. And heart and lung have the least cold ischemia time. This also you should remember. Kidney has maximum, heart and lung has least, which is less than 3 hours. And in heart, it is maximum of 6 hours. Which is why I'm sure you must have read in papers that whenever the heart is being transported, they create a green corridor, right? And my junior, who's a transplant surgeon now, who does heart transplants as well, he tells me that there's so much of coordination even in a place like India that as soon as the air ambulance or the flight lands, which is carrying the heart, then the ambulance is going to be escorted by 2 or 3 police vehicles and all the traffic is stopped so that the heart reaches the hospital on time. That is known as a green corridor. And because you're literally racing against time, you need all the help you can get to make the heart reach the patient on time. So these were the cold ischemia times for various organs. Now let's start talking about individual organ transplant. And first we'll talk about renal transplant now. Now, renal transplant, first you should know what are the indications for renal transplant. So the indications for renal transplant in adults, the most common indication for renal transplant is diabetic nephropathy. That is the most common indication. Whereas in children, it is glomerulonephritis. In children, the most common indication is glomerulonephritis. So one more thing which I want to cover here, that in adults, diabetic nephropathy is the most common indication for transplant. That is why in these patients, we can even do a simultaneous kidney and pancreatic transplant. Right, so kidney and pancreatic transplant can be done simultaneously or it can be done separately as well. But because if it is because of diabetic nephropathy, it is worthwhile doing a simultaneous kidney and pancreatic transplant. Now, just a few words regarding pancreatic transplant. So when we do the pancreatic transplant, we are going to carry out the anastomosis. So we do the anastomosis. The arterial anastomosis is done with the common iliac artery. The venous anastomosis is done with the iliac vein. And you can see that the pancreatic anastomosis can either be done with the duodenum or it can be done with the bladder. In this diagram, I've shown you the anastomosis with the duodenum, but initially bladder was preferred. Why people used to prefer bladder? Because you could monitor amylase in the urine, and that would tell us whether the graft is working properly or not. So, the monitoring could happen. But it has been seen that these bladder anastomosis, within a few years, they have to be changed. They have to be changed to an enteric anastomosis. Which is why these days enteric anastomosis are preferred when you're doing a pancreatic transplant. So these were just some words regarding pancreatic transplant which I wanted to cover here itself. Now, we know the indications when the patient will require a kidney. We know that there can be a live donor where a family member can donate a kidney, but there is always a shortage of donor organs, right? And that is for all across transplants, which is why you will read that there are transplant lists which are created where patients are categorized according to the severity, and then they're put in an order, and that's how they get matched with a donor. Okay, so to increase the number of donor kidneys, or to bridge the gap between recipients and donors, extended donor criteria for renal transplants have also been released. Now, expanded or extended donor criteria include any fit patient who is above the age of 60 years can be a donor, and a patient who is 50 years or more with 2 or more of the following: death due to stroke, history of hypertension, or serum creatinine more than 1.5 milligrams per deciliter. If 2 out of these 3 are also present in a dead donor, then also that patient is considered as an extended donor, and we can harvest the organ from these patients. One thing which I want you to know, when you harvest an organ from these extended donors, the survival is not as good as a patient who is a live donor or a younger patient, a fitter patient. The survival of the organ is also better. Now, before we do a transplant, and if you're doing a transplant from a live donor, there are certain investigations which you need to carry out in the live donor as well. And what are these investigations? So you need to do ABO compatibility. ABO compatibility needs to be done. RH compatibility needs to be done. Very important for the exam is HLA compatibility. HLA compatibility is very important, and within the HLA antigens, you should know that DR is the most important when it comes to renal transplant. So DR is the most important, followed by B, HLA B, followed by HLA A. So DR is dear for renal transplants. That's how you remember it, followed by B, followed by A. Of course, in patients, you will carry out a kidney function test. You will do an ultrasound KUB in these patients who are donors as well. And we will also do a renal isotope scan in these patients. A renal isotope scan. So if you remember the module on kidney, I told you about 3 renal isotope scans. And I told you MAG3 is the best for function. MAG3 is the best for function. Now, why am I doing a MAG3 scan in a renal donor? So if you remember, these MAG3 scans, they tell us about the total GFR, and they tell us about the differential GFR. Okay. So if the total GFR is 100, they will tell me how much is left and how much is right contributing to this 100. Okay. How much is left and right contributing to this 100. Now, what is the importance of knowing this? So, I will tell you in some time that left kidney is the preferred donor kidney. Is the preferred donor kidney. This I've told you in the kidney module as well. And why is the left kidney the preferred donor kidney? Because it has a longer renal vein. Because it has a longer renal vein, that is why it is the preferred kidney during renal transplants. But we just don't blindly go and pick up the left kidney from a donor. Now, supposing we do this renal isotope scan and we find out that the left kidney is working 70% for the donor and right is working 30%. And you happily go and remove the left kidney. Now, this poor donor who has donated his kidney, he himself would require a transplant now. Okay, so that is why we do a renal isotope scan to see how much both the kidneys are functioning, and then we take a call which kidney to harvest. So these are the tests which are done in a donor. So once the kidney has been harvested, it will be transported properly as we've discussed, and then it will be placed in the recipient. Now when we place it in the recipient, organs can always be placed in the orthoptic position or in the heterotopic position. What do we mean by these two terms? Orthoptic is when the organ is placed in the same anatomical area, like we'll discuss in liver transplants where it is placed in the same anatomical area. Heterotopic is when it is placed at a different location. And renal transplants are usually heterotopic. So that is why the renal transplanted kidney is kept in the iliac fossa. So it is usually a heterotopic transplant. It's a heterotopic transplant which is done. Now, when we are doing the anastomosis, what are the various anastomoses which are done in patients with renal transplants? So you can have kidney being taken from a dead donor, or you can have kidney being taken from a live donor. So the difference is that when we take kidney from a dead donor, we can take an aortic patch, right? From a dead donor, when I'm removing the artery, I can take an aortic patch as well. So that is why in a dead donor, you can see that the anastomoses which will be carried out are going to be an end-to-side anastomosis of the renal artery with the external iliac artery. So renal artery with external iliac artery, this is renal artery of the donor and this is external iliac artery of the recipient. Because you have a patch, you can do an end-to-side anastomosis. Okay. The venous anastomosis in these patients is going to be renal vein with the external iliac vein. Again, it's going to be end to side. And finally, the ureter will be anastomosed with the bladder. And whenever we do a ureteric anastomosis with the bladder, it always has to be an anti-reflux method. Remember in the kidney module, I told you that when you reimplant the ureter, it should be anti-reflux so that reflux does not occur. So we can either use the Gregor-Risch technique, or we can use the Ledbetter-Politano technique to create an anti-refluxing anastomosis of the ureter with the bladder. This was in the case of a dead donor. In patients with the live donor, I cannot take a patch, right? I cannot take an aortic patch. So here the anastomosis is an end-to-end anastomosis of renal artery of the donor with the internal iliac artery. Why not the external iliac artery? Because the external iliac artery is supplying the limb and you can't do an end-to-end anastomosis. You can't cut the external iliac artery and do an end-to-end anastomosis. Otherwise, the limb vascularity will suffer. The venous anastomosis is the same and the bladder anastomosis is the same. The only difference is in the arterial anastomosis, which I've told you the difference between a dead donor and a live donor. So this is how the transplant is carried out. Now we need to discuss what can be the potential complications in a patient with renal transplant. So the complication, the most important one for your exam is rejection. And rejection following renal transplants can be of three types. So you can either have hyperacute rejection, there can either be hyperacute rejection, or there can be acute rejection, or there can be chronic rejection. These are the three types of rejections which can occur in a patient with a renal transplant. Now, hyperacute rejection occurs because of preformed antibodies, and these are usually anti-HLA antibodies. And this is an example of a type 2 hypersensitivity reaction. This has been asked multiple times in the exam. So these are preformed antibodies, anti-HLA antibodies, and it's a type 2 hypersensitivity reaction which is seen in hyperacute rejection. Now this occurs on table. As soon as you do the anastomosis, the kidney is going to turn dusky and it does not produce urine, right? It turns dusky, no or bloody urine will come out, and the only thing is to remove the graft. You cannot salvage from hyperacute rejection. The kidney is ultimately going to go into the dustbin. Now the incidence of hyperacute rejection has gone down because of proper matching. And that is why I told you HLA matching is of paramount importance in renal transplants. When I talk about liver transplant, when I talk about heart transplant, their HLA matching is not that important because hyperacute rejections are usually not seen in heart and liver transplants, okay? But it is very important in renal transplant. Now, acute rejection is within 6 months. Acute rejection can be because of two reasons. It can either be T cell mediated, or it can be antibody mediated. Now, before I tell you more about acute rejection, I just want to show you regarding hyperacute rejection, what does the slide look like. So when you see a slide of hyperacute rejection, you will see intravascular thrombosis. You get intravascular thrombosis on the slide. So you can see here, you can see these clots inside the glomeruli, right? So you can see the clots inside the glomeruli, intravascular thrombosis, and you will see these clots inside the glomeruli as well. This is what you see on a slide of hyperacute rejection. Coming back to acute rejection can be T cell mediated or antibody mediated. The T cell mediated type responds well to immunosuppression. This responds well to immunosuppression. Whereas antibody mediated, less response to immunosuppression is there. Okay, less response to immunosuppression. But because of such effective immunosuppression, which I'm sure Dr. Ranjan has covered in great detail about the immunosuppressive agents which are used in renal transplant, because of such good immunosuppressive agents, the incidence of acute rejection has gone down. Acute rejection incidence has gone down, and the 1-year graft survival rate in renal transplants is more than 90%, is more than 90 to 95%. And this is one of the main reasons behind this is effective immunosuppression which is being used. So the final type of rejection is chronic rejection, and chronic rejection, you should now know, has become the most common type of rejection. Most common type of renal rejection is chronic rejection. So this is very important. Most common type of renal rejection is chronic rejection, and the most important factor for chronic rejection is previous acute rejection. A previous acute rejection episode is the most important determinant for chronic rejection in the future. So if there has been an acute rejection, very high chance of chronic rejection in the future. Now, because this is a gradual rejection which occurs after 6 months, this is a type 4 hypersensitivity reaction. This is type 4 hypersensitivity reaction. This question has also been asked in the exam. So this type 4 rejection is mediated by non-immune factors. It is mediated by non-immune factors, and that is why chronic rejection does not respond to immunosuppression. That is why it will not respond to immunosuppression. Please remember that. And in chronic rejection, if we see the slide, we will get glomerular sclerosis. We are going to get glomerular sclerosis in patients with chronic renal rejection. You can see glomerular sclerosis can be seen in chronic rejection. Okay. And this is now the most common rejection. So this is another point which I want you to remember. So we were talking about the complications. We've discussed about rejection. Rejection is extremely important from the point of view of the exam. Now, what are the other complications following renal transplant? Infections can be there, and infections in the first month following transplant, bacterial infections are more common, but overall, most common are viral infections. And why are infections common? Because we are giving immunosuppressants. So the risk of getting infections is higher. The most common viral infection is cytomegalovirus. BK virus can also infect renal transplant patients, but the most common is cytomegalovirus. BK virus can also be seen in renal transplant patients. Because these patients are being given immunosuppressants, there is increased risk of malignancy as well. And the most common malignancy are skin cancers. Are the most common. And amongst this is squamous cell carcinoma. Others can be hematological malignancies. There can be hematological cancers also which can be seen. So I have 2 patients now who have had renal transplants in the past and have now developed breast cancer. So one developed after 5 years and one developed after 10 years of transplant. They've developed breast cancer as well. So there is an increased risk of malignancy in any patient who's undergoing transplant. The other complications can be post-transplant lymphoproliferative disorder. So post-transplant lymphoproliferative disorder, PTLD, there has been one question which has been asked from this as well. This occurs because of Epstein-Barr virus. This question has been asked. High mortality rate, and this is usually seen in those patients where a lot of immunosuppression is given. So if immunosuppression is given for a longer duration, then there will be a higher chance of lymphoproliferative disorder. This is B-cell mediated, and CNS involvement, if it is there, it has poor prognosis. A very common transplant where PTLD is seen is bowel transplant, and I will cover that point later on in this module. Now, patients with PTLD can come with infectious mononucleosis like picture, or they can come with generalized lymphadenopathy, right? Children can also have generalized lymphadenopathy, and this can occur if increased immunosuppression is used in patients. The other complications of renal transplant, you can get vascular complications. There can be vascular complications. So vascular complications, the most common vascular complication following renal transplant is renal vein thrombosis. And if renal vein thrombosis occurs, there will be a sudden decline in renal function. There will be a sudden decline in function of the kidney. And that is how it manifests, and we have to use anticoagulants in these patients. And renal vein thrombosis can also be a manifestation of rejection, right? This can also be immune mediated and can be a manifestation of rejection as well. Renal artery stenosis can occur. Renal artery stenosis can occur in the long run, and this renal artery stenosis is going to manifest as accelerated hypertension. That is how the patient is going to come, and this hypertension will not respond to antihypertensive agents. A CT angio can detect this stenosis, and the management is just balloon dilatation, right? You can do a balloon dilatation of the renal artery stenosis, which is there. Another complication can be delayed renal functioning, delayed graft function. So delayed graft function is when a patient requires dialysis after transplant. When the patient requires dialysis after transplant, that is delayed graft function. And this is seen in around 10 to 15% patients can require dialysis after transplant as well. But overall, I told you that the survival following transplants has increased tremendously, and there is a more than 90% 1-year graft survival rate. There is a more than 90% 1-year graft survival rate, and there is a more than 80% 3-year graft survival rate in patients with renal, in patients with liver and heart transplant, right? So the overall survival has increased tremendously, and you should remember these values for the exam as well. Renal transplant values have been asked in the exam. So these were the points regarding renal transplant. Let's move on to liver transplant. Now, before I move on to liver transplant, like I told you, rejection can happen with any organ. So when rejection happens, you have a Banff classification to document rejection, right? So you have a Banff classification to document rejection. And this is a histological classification. This is a histological classification. To get the biopsy to see whether rejection is occurring or not, we need to get a biopsy from the organs. And how do we get this biopsy? From the kidney, liver, we can do a needle biopsy, right? A core needle biopsy like we've discussed. From the bowel, we can do an endoscopic mucosal biopsy. And from the heart, this is very important. This has been asked in the exam. To biopsy the heart, we need to do a subendocardial biopsy from the jugular root. So we go via the jugular root and then we can do the subendocardial biopsy. So this I just wanted to tell you, how do we get tissue to document rejection. Now moving on to liver transplant. So liver transplant, the indications for liver transplant. In adults, the indication for liver transplant is cirrhosis of the liver. And cirrhosis, is because of various causes. It can be alcoholic or viral cirrhosis as well. Most commonly, it is hepatitis C virus, more common than hepatitis B virus. And in children, the most common cause or the most common indication is extrahepatic biliary atresia. That is the most common indication in children. For transplant, this has also been asked in the exam. So these are the indications to carry out liver transplant. And we've discussed in the liver module that any patient who has cirrhosis, we have to quantify what is the functioning liver tissue remaining. And there are various scores to assess the functional tissue remaining. One is the Child-Pugh score. This I've covered in great detail in the liver module. You have to remember the Child-Pugh criteria, where Child-Pugh, there are score is from 1 to 3 and there are 5 parameters which are included. The parameters are bilirubin, albumin, encephalopathy, ascites and prothrombin time. And you have score ranging from 5 to 15. And Child-Pugh A is 5 to 6, B is 7 to 9, C is 10 to 15. And it is Child-Pugh B and C, which these are the patients who are candidates for liver transplants. You also have another scoring system that is known as the MELD score. This has also been asked in the JIPMER exam and INI-CET exam. MELD includes INR, creatinine, bilirubin, and this is modeled for end-stage liver disease score. For pediatric transplants, to assess the pediatric function, we calculate the pediatric end liver disease score, and this includes albumin, bilirubin, INR, growth failure, and age less than 1 year of age. So these are the 5 parameters which are included in the PELD score. Now, few things which I want you to know. One, that a patient with hepatocellular cancer, can also receive a transplant, and this I've covered in the liver 2 module where I've spoken about cancers. Only those patients who meet the Milan criteria with hepatocellular cancer can get a transplant. What is the Milan criteria? Where there is a single tumor less than 5 centimeters, or there are 1 to 3 tumors which are less than 3 centimeters, and there is no lymphovascular invasion. LVI is lymphovascular invasion, and there is no distant metastasis, no distant mets. These are the patients who are going to qualify for the Milan criteria, and you need to carry out a transplant, or you can do a liver transplant in these patients. Another question which has been asked in the exam is regarding the King's College criteria. So the King's College criteria is to determine which patients can get a transplant in patients with acute liver failure. So what are the criteria for transplantation in acute liver failure? These are the King's College criteria. And there's different criteria for acetaminophen-induced acute liver failure and non-acetaminophen-induced acute liver failure. So non-acetaminophen acute liver failure, prothrombin time more than 100 seconds or INR more than 6.5, or any three of the following. It should be a non-A, non-B viral hepatitis. The time from jaundice to encephalopathy should be more than 7 days. Age less than 10 or more than 40 years. Prothrombin time more than 50. If it is not more than 100 is a standalone criteria, but if it is more than 50, it comes in these criterias. And a bilirubin more than 17.4. So any three of these or this prothrombin more than 100 seconds, these are the indications to carry out transplant in acute liver failure, and you should know the terminology King's College criteria as well. This has been asked in the exam. Now, when we are doing a liver transplant, I told you there is no role of HLA matching. There is no role of HLA matching in liver transplant because hyperacute rejection is not seen. So there's no role of HLA matching because there's very less incidence of hyperacute rejection in liver transplant. Now, what are the various types of liver transplants which can be there? So types of liver transplants, you can have orthoptic liver transplant. Orthoptic liver transplant means that you remove the diseased liver. We remove the diseased liver, and donor liver is placed at the same anatomical site, that is known as orthoptic liver transplant. So if your car engine has stopped working, you remove that car engine and put the fresh engine in that place. That is orthoptic transplant, right? Same place we are putting it. Auxiliary orthoptic liver transplant, this is also being asked in the exam. This is done for metabolic liver disease. Please remember this. This is done for metabolic liver disease. So auxiliary orthoptic liver transplant is that diseased liver is not removed. Diseased liver is not removed. Diseased liver is still there, and we put a small piggyback transplant over that liver only. We put a small piggyback transplant over the diseased liver. That will be an auxiliary orthoptic transplant, right? So I'm sure you must have seen these science fiction movies where a spaceship goes to the moon or some other planet, and the climax of the movie invariably is that the spaceship cannot take off, right, because of some reason. And invariably the captain says that let's switch on the auxiliary power unit. So auxiliary means a reserve power unit. Now, when these patients have metabolic liver disease, the main liver is not working, okay? So to tide over that phase or to tide over that problem for a short period of time, we are putting a piggyback, a auxiliary liver there so that it can tide over that phase, and then the main liver will also start working after some time. Okay, so that is auxiliary orthoptic liver transplant. Domino liver transplant. Domino liver transplant or domino transplant for any organ. It can be for any organ, not only liver. This is when the organ is taken. This is when the organ is taken from a patient suffering from a systemic disease. Suffering from a systemic disease. So if you take the organ from a patient who's suffering from a systemic disease, we call it a domino transplant. And this started off in patients with hereditary amyloidosis, where patients with hereditary amyloidosis, they were taking the liver and giving it to another person. And they saw that it took many years. It took 7-10 years for amyloidosis to set in. So for 7-10 years, that liver was functioning in a good manner. Similarly, in 2019, there was a case which made the headlines where they said that one HIV patient donated a part of his liver to another HIV patient. So that will also be categorized as a domino transplant. Okay. Finally, split liver transplant. This is very important for the exam, and there is a diagram in both Bailey and Sebiston. Split liver transplant is if you're removing the liver from a deceased donor, then you can split it into two and it can benefit two people, right? So we've already discussed the surgical anatomy, and the split is that segments 2 and 3 of the left lobe, they will go to a child. These are smaller and they go to a child. And segments 4, 5, 6, 7 and 8. 4, 5, 6, 7, 8. These are going to go to an adult. So with one liver, we can benefit two recipients, and that is the advantage of split liver transplant. So we've discussed about the types of transplants. Now when we are doing liver transplantation, what is the sequence of anastomosis which is carried out in these patients? So the sequence of anastomosis in a patient with transplant, you can see the incision which is made. We need wide exposure. So we almost make a hockey stick kind of an incision. So the sequence of anastomosis is that first the suprahepatic IVC is done. Second, infrahepatic IVC anastomosis is done. And these vascular anastomoses are carried out using Prolene. Then we do the portal vein anastomosis. Then is the hepatic artery. And finally is the bile duct anastomosis which is carried out. So this is the sequence of events: suprahepatic, infrahepatic, portal vein, hepatic artery and bile duct. This is how we carry out the anastomosis in a patient who's undergoing liver transplant. Now, once we've done the transplantation, what are the complications of liver transplant which you should know about? So rejection, I've already told you there is no hyperacute rejection. There is no hyperacute rejection in patients with liver transplant because usually HLA, and that is why HLA matching is not important. Acute liver rejection can occur. Acute rejection can be seen, and acute rejection will manifest as sudden decline in liver function tests. Immunosuppressants are used to control it. Immunosuppressants will be used. Again, acute rejection can either have immune-related factors or non-immune-related factors. If it is due to T-cell mediated response, then it will respond to immunosuppressants. Otherwise, it does not respond to immunosuppressants. So finally, chronic rejection. Chronic rejection is also uncommon in liver transplants, but if chronic rejection occurs, there is a very common terminology which you need to know, which has been asked in exam. So chronic rejection, if it occurs when you do a biopsy in these patients, you will get the vanishing duct syndrome. You get vanishing duct syndrome. So the ducts become sclerosed on that biopsy specimen. That's what you're going to see, and that is a sign of chronic rejection in liver transplants. So this was regarding rejection. infections, malignancy, and PTLD is the same as renal transplant. Infections, malignancy, and PTLD, same thing as renal transplant, what I've covered. Vascular complications in liver transplant. So you should know here the most common vascular complication in liver transplant is hepatic artery thrombosis. And hepatic artery thrombosis is going to manifest as sudden decline in liver function. There will be sudden decline in LFT, in liver function tests. And if there is hepatic artery thrombosis, usually these patients will require a retransplant. That is what needs to be done in these patients if hepatic artery thrombosis is found out. Also, in the long run, these patients can develop biliary strictures. There can be biliary strictures which can develop in these patients as well. Okay. So these were the complications following liver transplant. So I've covered kidney and liver transplant. Majority of your questions are going to be asked from these two. Now, the other transplants, I'll just cover the salient points. These are important for your INI CET exam or the super specialty exams if you're preparing for them. Now, heart transplant, I told you that in heart transplant, this has the least cold ischemia time. And I showed you a short clip right at the beginning of how the heart is harvested. No HLA matching is required here. Because again, hyperacute rejection is usually not seen in heart transplants. Now, heart transplants can either be done as an isolated heart transplant, or heart and lung transplant can be done simultaneously as well. So if a heart transplant is being done, then what are the steps of transplant surgery, or what is the sequence of anastomosis? This has been asked in the super specialty exam. So the sequence of anastomosis is first the left atrium. First, the left atrium is anastomosed. Then the right atrium is anastomosed. After that, the right atrium. So left atrium followed by right atrium. Then you have the pulmonary artery, and then you have the aortic artery, which is anastomosed. So left atrium, right atrium, pulmonary, and aortic anastomosis. These are the four anastomoses which are carried out in heart transplant. To assess if rejection is occurring, or not, then we can do a subendocardial biopsy. And this subendocardial biopsy will be carried out using the jugular route. So we go via the jugular route, and then we are going to carry out this subendocardial biopsy to confirm the diagnosis, whether rejection is happening or not. Now, like I told you, lung transplant can either be an isolated lung transplant, or it can be done along with heart transplant. And if you're doing a lung transplant, then what is the sequence of anastomosis? So when we are doing a lung transplant, the pulmonary vein along with the cuff of left atrium is taken. Right? So from the donor, we take the pulmonary vein along with the cuff of the left atrium. And in the recipient, we need to carry out a posterolateral thoracotomy. We need to do a posterolateral thoracotomy to carry out this transplant. Now, this pulmonary vein along with the cuff of left atrium is anastomosed with the left atrium of the recipient. Then we carry out the bronchial anastomosis and then the pulmonary artery anastomosis. So these are the three anastomoses in this order which are carried out in lung transplant as well. Now, finally, I want to talk about small bowel transplant. I told you in the small and large bowel benign module when I was talking about short bowel syndrome that I will cover small intestinal transplantation in the transplant module. Now, small intestinal transplantation has not progressed as much as the other transplants have progressed. And even the survival in small bowel transplants is not as good as in other organs. And the reasons for that are certain challenges. Challenge number one is that there is large amount of lymphoid tissue which is there in small bowel. This leads to increased rejections, and there is increased risk of GVHD as well, graft versus host disease. This also I will discuss in the complications. And whenever ischemia or rejection occurs, in small intestinal transplant, that increases the permeability of the bowel. And what is going to happen when the permeability of the bowel increases? Then bacteria are going to go out of the bowel. And if bacteria go out of the bowel, they will cause infections, right? They will cause infection. So graft rejection and infections are the leading problems which are leading to inferior outcomes in small intestinal transplant. Now, small intestinal transplant, the indication for small intestinal transplant is a patient with bowel failure or short bowel syndrome on long-term TPN. So, short bowel syndrome patients requiring long-term TPN. We've already covered short bowel syndrome in the small and large bowel module, and we know the various causes of short bowel syndrome like superior mesenteric artery thrombosis, like superior mesenteric artery embolism, or it can be Crohn's disease or volvulus or atresias in children. So all these are causes which can give rise to short bowel syndrome. Now, long-term TPN does help these patients. In fact, in children, it has been seen that a lot of patients where long-term TPN was given, small intestinal transplantation was avoided, right? So, but those who are developing complications because of TPN or are not able to tolerate TPN, those are the ones who will require a small intestinal transplant. So, small bowel transplantation, isolated small bowel transplantation can be done, or in these patients, a combined small bowel and liver transplantation can be done. Why are we doing a liver transplantation? Because these patients are on long-term TPN, and because they are on long-term TPN, remember the nutrition module? I told you in long-term TPN, they can develop cholestasis. And because of cholestasis, they can develop liver dysfunction as well, which is why in certain patients, a combined transplantation can be carried out. The 1-year graft survival rate is 80% and the 3-year graft survival rate is 70%, so it is lower than other organs, and there is high incidence of lymphoproliferative disease. PTLD is very high in these patients. Also, I told you about GVHD. So, graft versus host disease. This is graft versus host disease. And this is mainly seen in small intestinal transplant and bone marrow transplant. And in these two transplants, what happened? That the donor lymphoid tissue, the donor lymphocytes, they go and attack the host immune system. Now, we know that the host immune system is already suppressed with immunosuppressants. So, these lymphocytes, these active lymphocytes can easily attack the host immune system. And this can give rise to a characteristic rash on palm and sole. Right, and here I want to tell you there is a very dear patient of mine. She was 21 when she was diagnosed with leukemia, and she underwent a transplant, a bone marrow transplant. And it was so sad because she was selected for Harvard, and after receiving her Harvard selection, just within 20 days, she was diagnosed with leukemia. And I'd put in the chemo port for her. I'm still in touch with her, and she's developed such bad GVHD that entire face skin, entire hand skin is just getting peeled off, right? Also, they can develop GI disturbances. There can be diarrhea, and liver dysfunction also can be there. And liver dysfunction can also be seen in graft versus host disease. So this is common in small intestinal and bone marrow transplant. So this brings us to the end of the module on transplantation. Usually now in the MCQ exams, there is a question from transplantation. So you should go through this module for your entrance exam. From the final year point of view, hardly any questions have been asked as short notes. So just a brief idea about transplantation is good enough from the final year point of view. Let's do some questions before we end this module. Using porcine heart valves in human classifies as a xenograft. This we've already discussed. So which of the following is an extended donor criteria for renal transplant? Donors older than 45? No. Age more than 52? No. It should be more than 60 or 50 with 2 or more of the following. So 52-year-old with diabetes, hypertension, creatinine more than 2. Hypertension is a factor, but creatinine is 1.5, more than 1.5. So this patient will not classify as an extended donor. Death due to stroke caused by hypertension. Yes, this patient classifies. This is the true statement. This is the correct answer. These are the extended donor criteria. I've told you that either the age should be more than 60 or 50 to 59 with 2 or more of the following: stroke, hypertension, or creatinine more than 1.5. A patient undergoes renal transplant and is producing good urine out on the table. He is shifted to the ward and there is no urine output, but nephrostomy tube is draining urine. What is the most likely cause? So nephrostomy tube is draining urine, but the Foley's is not draining urine. So this clearly says that there is a catheter blockade, and you just need to be careful that the catheter is not blocked, otherwise it can also affect the renal function. Hyperacute rejection, we've discussed, occurs in kidney. Which of the following statements is not true regarding hyperacute rejection? Occurs within minutes, mainly driven by HLA-DR. No, it is driven by all the HLA antigens. So it can be DR, B and A, right? DR is the most common, but it can be B and A as well. Previous blood transfusion is a risk factor and it is type 2 hypersensitivity. This is correct. Most common indication for small bowel transplantation is bowel ischemia, which gives rise to short bowel syndrome. Which of the following statements is false regarding Milan's criteria? It is used for liver transplantation in hepatocellular cancer. Transplant is indicated in a single tumor less than equal to 5 centimeters without distant mets. True. It is indicated in 2 tumors less than 3 centimeters without distant mets. Indicated in 3 tumors less than 2 centimeters without distant mets. So in 1 to 3 tumors less than 3 centimeters, this can be done, and 3 tumors also less than 2 centimeters, it will work. So all these statements are correct in Milan's criteria. All the statements are correct here. The correct definition of fulminant hepatic failure, this was asked in one of the exams. The correct definition of fulminant hepatic failure is development of encephalopathy within 8 weeks of jaundice. Within 8 weeks of jaundice is fulminant hepatic failure. What is the correct sequence of anastomosis in heart transplant? The correct sequence is left atrium, right atrium, pulmonary artery, and aorta. So these were the points regarding transplant which I wanted you to know. Thank you.